All right, so the next step in being able to manage a patient's both airway but also breathing is actually using what we call our bag valve mask, which is this device here, which I'm sure you've all seen on TV shows and different places. This is designed to use on a patient who is not breathing effectively on their own. So for patients presenting cyanotic, they're apneic, which means they're not breathing effectively or not breathing at all. For an adult, a respiratory rate under about 12, maybe 10, this patient's not breathing effectively on their own, therefore we need to assist. So if a patient is breathing spontaneously, effectively on their own, we're not going to be using a bag valve mask. But for any patient that's not breathing effectively, we're going to. There's 3 different sizes. This one here is for your adult. They're all come exactly the same setup, they're just different sizes. So you have the mask, which is this section just here. So the mask here, pointy parts of the nose, down around the mouth. That then pushes onto your bag valve mask here. You then have the main res of the bag here. So this is the part that we squeeze. For this bag here, for an adult patient, the total volume in this particular bag is 1,500 millilitres that sits in this bag, and then we can squeeze that out. The end bag here, which is your reservoir bag, is connected on all of them, and that will inflate once we connect this to oxygen. So this little part here, this little plug just here, is where we connect the oxygen tubing, and that then connects to your oxygen cylinder. We use 15 litres of oxygen per minute. That will inflate the reservoir bag. Then as we squeeze our bag valve mask here, it will pull the oxygen from your reservoir bag through this section here down into the mask and deliver that to your patient. In saying that, you don't always have to have this connected to oxygen. It does take time to connect oxygen to it, and if you have a patient who's not breathing effectively on their own, we want to start ventilating this patient as quick as possible. So if I were to squeeze this bag here now without being connected to oxygen, what it is doing, it's actually using room air oxygen. So in room air, we have approximately 21% oxygen. So by purely doing it like this, without being connected to oxygen, I'm still delivering 21% oxygen to my patient, which you can begin with whilst other things are being set up. That's an adult bag. The pediatric child bag here, you see that it's just smaller. We've got the bag here that we squeeze. We've got a reservoir bag. We connect it to oxygen. Exactly the same process as with the adults. The only difference is there's about 500 to 550 millilitres volume in this bag here. And obviously the mask is smaller. The other bag that we also have is your neonate infant. So tiny, tiny, tiny little bag here. Same setup with everything else. You've got your mask, which is very, very small, popped on here, reservoir bag, and the volume sitting in here is approximately 300 millilitres. So once I squeeze that bag there, I'm not going to be able to push out any more than that 300. So if I was to use an adult bag on an infant patient, we potentially could actually create a lot of damage and create more issues. So making sure we get the correct size bag valve mask. Now the process of using these is actually very, very simple. So what we're actually doing is providing that intermittent positive pressure ventilation, so IPPV, which you may have read about in your studies. Key considerations with your patient: not breathing effectively on their own, cyanotic, they may be apneic, respiratory rate for an adult under 12, you may need to assist them. Is getting a really good seal is a priority, because if I were just to go and put this bag over this patient's mouth like this and squeeze, nothing's happening. So we want to seal all the way around. We can do that by using what we call a C E-grip. So C, I'm just going to take this off here just for a moment to show you on the actual mask. C goes around the mask. Then my 3 fingers here will actually go underneath the patient's jaw, and we're drawing the patient's jaw into the mask. And that's going to assist us in getting a really good seal. And pop that on. So pointy part here to the patient's nose, covering the patient's nose and mouth. C around our mask. E, so these 3 fingers are now going to pull in underneath the patient's jaw, and I'm going to try and pull that jaw on the patient's face into the mask. We're not pressing down as such because that's going to cause a lot of damage. We're going to pull our patient's jaw into the mask. From here, all I need now to do, I have that seal, is I just need to squeeze my bag and you'll actually see this chest rise. I'm just going to move these for a moment. So we've got a good seal here, we've got a good C, we've got a good E grip. By squeezing my bag, I can now see my patient's chest rising. Considerations is we don't need to be really aggressive squeezing this like that. That can actually cause barotrauma. We can then overinflate into the stomach. We purely only need to squeeze nice and gentle on this bag. As soon as you see that chest rise, that's enough. You can also have, depending on how comfortable it is for you, underneath, and we can effectively sit here managing that patient's airway effectively like this with a head tilt or jaw thrust, or we may actually have an OPA or an NPA in there as well. Good CE grip, nice good seal, and gently squeezing the bag for that patient's chest to rise and fall.